I'm happy to go if you want to give me control.
Okay. This is Howard, everybody. Jeff's not here this week, so we'll start, and I'm going to have Travis start. So
Okay,
we see screen good.
I've got a few. I see the Seth's on there now, so I'll start with this one. This was an interesting case that came in. Uh, this was a couple of months ago, and I'm gonna kind of go backwards because I think it started off less interesting than it ended up. So we were asked to biopsy this patient at this point, and this is a man in his 50s, as you can see. He's got left upper lobe collapse or some left upper lobe consolidation, maybe some collapse, and this big necrotizing mass with an air fluid level in the middle. But what's interesting here is check out that he's got pericardial thickening and pericardial fluid, and then he's got this big soft tissue mass that's contiguous, or at least we thought maybe contiguous with that left upper lobe stuff. And it really just encases the coronary arteries but doesn't collapse them at all. So we were thinking, I looked at this first and I thought it was probably lymphoma,
Yes.
was going to be my first guess. You're in agreement, Seth?
Yeah, I would have definitely thought lymphoma. With the cardiac stuff, mostly it looks very good for lymphoma.
Yeah, and that's exactly what we thought. Well, then we got this old PET from July, which actually just confused us more. So I'll show you in a second. And you'll see back in July that he had just the stuff in his left upper lobe, and it was this nasty necrotic, partially necrotic thing. And I have no idea what these cysts are in the lungs. I don't even think I ever looked at the lungs in this guy. But yeah, so it kind of started out like that, and his heart was completely normal. But they tried to biopsy this and got nothing back then. So we rebiopsied some of this, and they did a transbronchial biopsy as well, and it did actually turn out to be diffuse large B-cell lymphoma. The lung was actually lymphoma as well. It's just bizarre that this started out as some sort of lymphoma in his lung and then ended up in the pericardium. I don't know if it's contiguous here or not. And then it kind of looked more like lymphoma on this one.
Yeah.
So, but I think when people were looking at it chronologically, then they were thinking, well, is it metastatic disease from a lung cancer? And since I wasn't biased by the previous one, I was like, this looks like lymphoma, no diff, really.
Wow.
But it did turn out to be a diffuse large B-cell lymphoma.
And
So,
it's the months to grow to get that size and so on. Yeah.
yeah.
Wow.
So I guess it was involving the lymphatics and then just ended up in the pericardium and circling the heart as well. So I thought that was kind of interesting.
Yeah, that's a great case.
Yeah.
All right. I'll show this one that I just came across again this morning. I kind of lost this one from a few months ago. This is a patient who's had a prior renal transplant back in 2007, and I don't remember what it's for. I don't think it necessarily matters, but he came in with this CT, and you see all of these randomly distributed nodules, a lot of which have surrounding little ground glass halos. Now, he's got this slightly different appearing stuff in the left lower lobe, and you can see in this area it's actually higher attenuation in the left lower lobe, and I'll come back to that in a second. But this was called most likely some sort of viral pneumonia, or maybe even a hematologic pneumonia, and we didn't have the clinical history at the time, but he came in at this time with a big vesicular rash, and so this is a great look for disseminated varicella, which is what this turned out to be in the setting of his immunosuppression from his prior renal transplant. What's interesting about this stuff in the left lower lobe is it looks very much like metastatic pulmonary calcification. It's kind of weird that it's just in the left lower lobe, and it's weird that it's unilateral. And going back to an old radiograph back in 2006, or 2007, this is around the time of his transplant. He didn't have that there. But on the follow-up that was just done this morning, when now he's got the residua of the varicella pneumonia, which is just the small little nodules without the ground glass anymore, and sometimes these will calcify. But then he still has this, which I think is probably just some sort of metastatic pulmonary calcification, maybe from an old pneumonia in the setting, with his end-stage renal disease. I don't know. What do you think?
Oh,
I was thinking it looked like metastatic calcification when he
Yeah.
first showed it.
Yeah.
Just
Oh,
that
yeah.
fluffy calcified appearance.
Yeah.
Yeah.
Yeah, it's kind of cool that's really unchanged. The one thing I forgot to mention is I saw this too. This is big calcified thing in the pulmonary artery to that lower lobe too. So I don't know if he had an infarct that could
That's
have
weird.
been the precipitating event for ending up with this metastatic pulmonary calcification, or if this is or something else that caused the calcium to deposit there. But he still has that thing in the pulmonary artery there, right in that left lower lobe.
Huh.
But
Did
typical
you just
evolution
have
of
pulmonary artery and not
varicella.
Travis? You think that's not a lymph node down there? It's pulmonary
I
artery.
think, yeah, I think it's in the artery right as it branches here.
Hmm.
You can see
Yeah,
kind of,
looks like it.
yeah, and then it branches again. So I
Huh.
have no idea, and we've never given him contrast. So I have no idea what it is or why it's there. But yeah, it does look like it's just a little calcified filling defect in the artery.
So a calcified thrombus and a calcified infarction. That would make a lot of sense.
Yeah, maybe so. Yeah, and then just with the acute varicella. So I guess, I mean, I know I've seen other cases of varicella that look like this, and I haven't had a chance to read up on it. But is it more of a hematogenous dissemination of the infection? Is that why you get more random nodules? Because I know we see this look, and it's usually seen in the setting of a vesicular rash, and they call it disseminated. And does anybody else know the exact um, explanation for that, as opposed to like an airway-centered pneumonia?
I've always just assumed that it's an airway pneumonia, not viral, not hematogenous. Oh,
But it does circulate in the bloodstream, so you can get viremia, and so
Yeah.
this could be either, I think.
weird.
And I just showing this, I probably showed this in the past, but it's the other good example of varicella pneumonia I have. And this is one from Emory. I don't remember the history of this patient, but this was, as you can see, just a neck CT. And you can see similar, just extensive nodules, a little bit of ground glass. These aren't as well defined or solid, but they did a follow-up CT of the chest 4 months later at that time, and you'll see that this now looks very similar to that one I just showed you, how they evolve into small little residual nodules that sometimes calcify. So, yeah, just another case of varicella pneumonia.
Great.
I don't,
Oh,
do you ever think of other infections that cause this kind of look? Because I kind of just associate this with varicella more so than other viral pneumonias, but I don't know.
I mean, why would you say if someone's not severely immunocompromised, it's not angioinvasive aspergillus or some
Well,
angioinvasive fungal infection with halo?
I guess the only reason we
Mine
were
is the
trying to,
calcified stuff in the left lower lobe.
yeah, well, right. No, you're just saying because you have all these nodules with ground glass halo.
Yeah.
I guess I was, because one of my residents asked that question this morning, and I said, I don't know, but I've never seen angioinvasive fungal infection this extensive.
Okay.
So I don't know if anybody else has any better explanation.
You know, the one fungal infection that could be this extensive would be Candida glabrata. It likes to be, it can be all over the place. But in general, if this were aspergillus, you'd have fewer nodules. You wouldn't have the plethora that you have in this case.
And if it's Candida, would you expect that to be hematogenous spread rather than an airway, or rather than an angioinvasive disease? I don't know. I'm just, yeah, because,
I haven't thought that deeply about it.
okay. Because Seth,
The
it's
other
a good
thing,
question.
like, angiosarc Mets or other very hemorrhagic Mets I've seen do this, but again,
Yeah.
not common.
Yeah,
Yeah.
I thought that's what this was. I thought this was going to be angiosarcoma of the right atrium or something. When it
Yeah,
first-
and the angiosarcoma Mets definitely have that kind of look too. All right. This is just a quick radiograph case. I think I've only seen, I know I've missed several of these, but this is the first one where I actually saw it prospectively, or one of the first ones I've ever seen. This is a young girl, and I noticed that she had this peculiar contour here. Turns out it was already a known diagnosis. But you can see that, she's got her aorta, and then you kind of lose the aorticopulmonary reflection here, and then there's this, this upward coursing contour right here. This did actually turn out to be an anomalous pulmonary vein. They knew it. Surprisingly, it was just an isolated left upper lobe partial anomalous pulmonary venous return, and they operated on this and redirected it to her left atrium. And I'm not exactly sure why, because this is one we see all the time, and I don't think I've ever seen them operate on it, because she didn't really have that significant of a shunt. Now, she also has an aberrant right subclavian artery, which I don't really see that well on the lateral view here. I don't see any mass effect on the trachea. But occasionally, you'll see this kind of contour sweeping up there from the anomalous pulmonary vein. But I just thought it was a nice radiographic correlate right here. So just below the aorta, giving you that kind of line right there. So
yeah, that one it's unusual to be able to see it like that.
I think it's
on radio.
I think it's probably because she's pretty thin. Yeah.
Yeah.
She doesn't have all the usual mediastinal fat.
Exactly. To perceive that vein going up like that so nicely.
Yeah.
That's a good pickup.
Cool. Yeah. So, but I think it's just that she doesn't have any mediastinal fat. All right, and sticking with chest radiographic abnormalities, this is a quick one I just saw a couple days ago. Wrong radiograph. And this is an old radiograph where they commented on some tortuosity of the aortic arch, and it's not the best radiograph, but you can see there's a little bit of mass effect and rightward deviation of the trachea, and there's a little bit of calcification of the arch. The lateral view doesn't do much for me. I think it's not that great of a lateral view. But this patient had a radiograph or a CT after that radiograph, and you can see that what was causing that was this big calcified pseudoaneurysm. And it's a great location and a great look for old traumatic aortic injury. As you can see, the calcification is largely just confined to that area. He does have a little bit of atherosclerosis, and it really looks more like a mushroom. But he did have a history of severe trauma in the remote past, and sometimes you can kind of suggest the diagnosis on the chest radiograph if there's old rib fractures, but he didn't have any fractures in his chest. But they did end up stenting that. I don't know. I think we've talked about this before, because I know I've shown this before, but if it's been there for 20 years or 30 years, like what the chance of it actually rupturing, I don't know.
Right.
But they did stent across it. But
yeah, that's a lovely histograph. Yeah.
Yeah, I actually, this was a VA case. I have another more recent radiograph that was still before the treatment where I think it was a little bit more conspicuous. I'll try and pull up. But it's a great CT here, too, where you just see the calcified saccular pseudoaneurysm, and you can imagine where the disruption of the wall was before. So.
Yeah, very much so.
All right, I'll show one more radiograph, just a quick case, and then we'll pass it around. This is just a fun one because it's kind of an eye test on both the PA and the lateral view, and it's a nice one too because there's a lot of findings, but you see that he's got this couple of weird contours along the right mediastinal border, and if you notice the comparison with his oldest radiograph, and I pull this up, he does have a little bit of a tortuous aorta, but it just looks a little bit, like there's an extra line here. And also you can notice that his bones everywhere else are diffusely abnormal. And now he's got diffuse blastic foci throughout his axial skeleton. So his diagnosis of metastatic prostate cancer wasn't a secret at this point, but I thought the lateral view was kind of interesting. And it's a good example of a non-anterior mediastinal mass occupying the retrosternal clear space. And so he does have this new thing right here, which is projecting into his anterior mediastinum, and on the CT, it turns out to be a big sternal metastasis that was just projecting backwards, which kind of accounts for that weird contour that you see on the PA view. So I think this is his tortuous aorta you see right here, and then this is that weird portion of this sternal metastasis that's projecting back and giving you a second interface. You can even see, you know, the inferior margin of it right there. So
Yeah.
definitely a lot more obvious on the lateral view than it is on the PA view. But I thought you guys might like that, Howard.
Yeah, I always like those cases.
So,
Lovely.
all right, I'll stop for now. Let you guys take over.
Because you're showing some neat radiographic cases, let me show some as well, just to continue the theme of nice radiographic findings. And then I'll hand those over. So let me bring this up. So again, the point here is kind of just to show interesting cases, not to indicate that the findings should have been seen before, but just to show some nice anatomy and some subtle findings and some hidden lesions. And you know I kind of like those cases. So let me start off with this one. And I'm definitely showing this one out of order. So let me bring up the frontal and the lateral. And start again here, bring up the lateral alongside. So give you a moment to look at that. For sure, this finding is not visible on the frontal projection at all. And as I'll show you in a moment, super subtle on the lateral projection. And this was obtained after the CT, so this is not in order. But just for the anatomy's sake, here is the finding. So knowing the hilar anatomy, this subtle rounded thing projecting in front of this vertebral body, and here is left pulmonary artery, but this rounded thing shouldn't be there. So again, wouldn't see that prospectively, but that is this finding, which was an incidental finding on a CT done to actually look for a source of emboli to an extremity. So this was a completely incidental finding. So this is the mass that corresponds with that. And this turns out to be an adenocarcinoma. So an incidental discovery of an adenocarcinoma in that superior segment. So just a subtle finding.
That's, Howard, that's on the right or the left?
The is on the right, sorry.
Okay.
Right there. Unfortunately, several of these subcoronal nodes, although not big, did contain tumor. So unfortunate.
So, Howard, the other cool thing about the plain film on lateral view is you don't see the PWBI, the posterior wall of the bronchus intermedius.
Clearly, let's have a look.
There's a thin white line, and this mass is probably obscuring that white line.
Should be more to find about here.
Right.
Yeah. Yeah. Okay. This next one is even more subtle. So again, I'm just going to show you what one sees in the retrospectoscope, not prospectively. And I will go back to, again, out of order to show you this one. So this goes back a couple of years. This is from 2014. And I will tell you that the small pleural effusions are not part of the case. I don't know why she had the pleural effusions back in 2014. The azygos was a bit distended. Perhaps there was an issue with fluid overload, but I don't know that. But the finding here, again, is on the lateral projection, not visible on the frontal projection. But I often teach that in the region of the confluence, or rather that pulmonary veins, inferior pulmonary veins going into the left atrium, if you have the right degree of obliquity, sometimes you can see a nodule or a pseudo-nodule. But this is the location of a pseudo-nodule. Except in this particular patient, this is a pseudo-nodule because it actually is real. And what's really subtle here, again, just looking retrospectively, is a little opacity just behind the major fissure of a lower lobe. So this is this rounded thing on the lateral projection. So quickly, just to complete the case, eventually she was diagnosed with a carcinoid, which produces that finding. Sorry, this is a MIPS, which I have. I don't think I have a non-MIPS. But the lesion obviously now is associated with the post-obstructive process. But the lesion is sitting in here, and this is a post-obstructive phenomenon with material in the bronchi. And as you might expect, that is a bronchial carcinoid. Actually, let me show you this because it shows that really nicely. So here is the lesion. Here is the lesion. That is the top of the carcinoid that you'll see with bronchoscopy right there. Here is the extrabronchial component, kind of the iceberg sign. But undoubtedly, she had that back in 2014, and then a variable amount of material in the lumens of bronchi behind it. So just nice radiographic findings. Again, really subtle. This one here is another one, just a great example of radiography and correlation. So let me bring up the lateral alongside this frontal. And again, the finding here is really on the lateral projection rather than the frontal projection. So let me just put that in the middle and show you quickly the really nice opacity with an incomplete border sign that we see here of an extrapleural lesion. It corresponds with this vague opacity there. And if you see that and you really zoom in a bunch, and if you're lucky, you can perceive that the rib is destroyed. So this is a rib plasmacytoma producing a subtle extrapleural sign. There's the rib lesion right there. So a nice example of an extrapleural sign on the lateral projection there. Okay, this one is one that Travis is really going to like. Are you still on there, Travis?
Yeah, I'm still here.
Okay, so this one you'll like. So here is, I don't know if I showed you guys this one before. No, I don't think I did. So here's a nice example of an opacity over there. If you look at it, you'll see that the interface of the opacity with lung is sharp and defined all around. So this is the non-cervicothoracic sign. With the cervicothoracic sign at the level of the thoracic inlet, the interface of the opacity with lung will disappear. So this one remains. So this is not a lesion at the level of the thoracic inlet, paratracheal, but somewhere else. So now let me bring up the lateral projection and just bring this up a little bit. So of course we think posterior, and we look posterior, and we know where to look. The lesion's not here, so it's got to be behind. So we look there and we look there, and is it paraspinal or not? So I'll bring it up alongside here, and you'll see there it is. So it's not paraspinal, but it's just behind the trachea in the radius triangle or the retrotracheal region. So this is pretty typical by location for a retrotracheal vascular segment, not a paraspinal lesion. And here is the thing. So it's a nice dilated aberrant right subclavian artery, really big, lots of atheromatous calcification and intraluminal thrombus. And I think the patient was admitted to have a stent put in this thing. So a nice CT and radiographic correlation for that case.
Yeah, that's really cool. And you can see the inferior margin of it in Rader's triangle and that radiograph you have there, I think. That little oblique line just above the aortic arch, yeah.
Somewhere about there, yeah. That's about where it is. Yeah.
So that's interesting too, because it's not a diverticulum off the aorta, it's just an aneurysm beyond the retroesophageal segment. Huh.
Yeah, it's dilated right from the origin, right? It's just all the way dilated. Right.
How old is this person?
This person, David, is 76.
Because this vessel is tortuous, comes off at a funny angle, and has to make all these sharp corners and things like that, it has a lot of turbulence and is prone to basically turn into an aneurysm early. And this person is 76, so it's had lots of time. So these deformed vessels are prone to become atherosclerotic and dilate and get aneurysmal.
Yeah, I've always wondered about that, why we see this uncommonly compared to the common non-dilated aberic right subclavian artery. Just a super nice example of that.
Very
I
nice.
guess the concern is that, this thing may rupture. I don't know about the prevalence or incidence of embolization of fragments of thrombus and distal embolization. Of course, I don't think this person did, but you can imagine this compresses the esophagus and producing dysphagia and all those classic associations of this kind of lesion. But this is unusually big, right? Dilated. Okay. Let's see if I have. Okay, another one just for a nice, again, continuing the radiograph theme. So here is this person. Give you a moment to look at this chest radiograph. So if you were to view this at the usual settings, you'd be hard-pressed to see anything, or you'd be pretty lucky to see anything. So now I'm going to put up the lateral alongside it. And this is a super nice teaching case of an opacity that is seen really nicely on the lateral projection, not the frontal projection. So here it is, the opacity projecting over the spine. There is cavitation within. And of course, if you now do this and change the window width, then we know where to look, and we can see it right there in the posterior basal segment. So a nice teaching case of the finding on the lateral projection. Necrotizing pneumonia. Here's the CT. I don't think they ever recovered an organism, but he's doing okay. Treated him as community-acquired necrotizing pneumonia for this. Just a nice.
This would be great for aspiration too, wouldn't it? I mean, this could well be aspirated anaerobe or something.
Yeah, it may not be just your everyday community-acquired pneumonia, right? Okay. Let's see. Yeah, there's some stuff in bronchus here, but I don't really know. But that's a thought, yeah. Just a super nice teaching case for the lateral projection. Okay, I'm going to stop there. And Seth or Brent?
Yeah.
Okay, Seth, there you go.
Yeah, I got cases.
I have two quickies, Howard.
Okay, Seth, then David, and here you go.
The first one, I'm just going to show some cine movies because it's a lot easier. This is a woman who was, 75, 80 years old, came in with very bad shortness of breath, and these are 3-chamber views, and you can see here, it's very bad chordal SAM where the anterior chordae and part of the mitral valve apparatus gets pulled into the outflow tract, and you can see a very strong dephasing jet, very high gradients across the LVOT. And this is not, the question is what do you call this? This is not that super uncommon. There's mild, very mild thickening of the anterior septal segment at the base, not much, 15 millimeters, 16 millimeters. And, I often refer to this as kind of like a sigmoid septum, but it's interesting to note in the literature that, some people refer to this as adult onset hypertrophic cardiomyopathy, and this would be hypertrophic obstructive cardiomyopathy. And you can see here, if I can get it to stop, the base really isn't, it's just not that thick. And it's interesting, and there's no delayed enhancement here, so there's no, well, that's not very, there's no scarring in that area of the base where it's a little thick. And, I was going back and forth with my clinical colleagues about, what do we call this when you see this? And here you can see the cord actually getting pulled into the outflow tract right here.
Can you show that?
Do you call?
Yeah, can you point that out?
Yeah, so unfortunately it doesn't let me.
Okay.
So here you can kind of see this is part of the cord getting pulled in here. This is the chordal attachment to the mitral valve. Oop, right, there we go. Kind of gets pulled up, and the whole thing, and the cord and the anterior portions of the anterior leaf will get pulled up here, and they're, the outflow tract severely narrow. She was very, very symptomatic from it. And so this was interesting because she was very symptomatic and went to myomectomy. And the question is, what are you going to see on myomectomy? Well, what I was very pleased to find out is they did a myomectomy. They took out a big chunk of tissue, and the myocytes were completely normal. There were no, there was no myofiber disarray. There wasn't even myocyte hypertrophy. They were completely normal myocytes. And so I just refer to this as kind of a sigmoid septum, which is some people refer to an aging thing. But again, if you look in the literature, some people will call this hypertrophic cardiomyopathy with outflow obstruction. And really, this is not an infiltrative process. The myocytes, at least here, are normal. There was some subendocardial scarring or fibrosis, but that was from the actual high-velocity jet smacking against it, which is not uncommon. So, this is something we run across not infrequently, and patient is labeled as having occam when they're 90 years old or 85 years old. I don't know if other people have experience with it, but this is the first one where we actually have a chunk of tissue showing that tissue is actually completely normal. And then this is just to show, I never like to show misses, but this was missed by someone in our group. The coronary arteries are definitely ratty. I mean, they're not good. There's multiple areas of calcified, non-calcified plaque. You can see there's this large focus on non-calcified plaque here with some positive remodeling, an aneurysm distal to it, another area. But what was kind of disappointing to me was, and I guess because I saw the after effect, that it was basically called areas of mild to moderate stenosis, nothing really severe. But if you look at this circ, this circ gets trashed really right at the bifurcation between if you call this a ramus, then this would be, maybe that's a tiny first OM. This really small second OM goes away, and it is severely stenosed. And the reason, you can see it here in the short axis as you're going transverse to the vessel. Here it is, it's small, but it completely goes away and comes back. And this was missed, and the reason I'm showing it was because the guy came back a few months later. You can see the date is a few months later with an NSTEMI, and if this will scroll, which it won't for me because it's being a pain in the butt, you can now see that he has infarcted this area. And this is not, and there was no evidence of infarct on that prior CT, and I don't know if I have, here's another area just showing the infarct, but another thing what I wanted to show, which I don't know if I included just on these limited slices, is that there was also, if I can get to the right slice, yeah, come on. I don't know why this is being a pain in the butt, but there was some pericardial, oh, here we go. There was some pericardial enhancement adjacent to it. So, this is probably some post-infarct pericardial inflammation, whatever you want to call it, if you want to give it an eponym or not, but some focal pericarditis adjacent to it, suggesting that this is probably, a week or two or maybe a few weeks old. But, it just goes to show that, yes, these stenoses that are there can, if they're not detected, lead to infarct. And this guy clearly developed an infarct in that area. So that was unfortunate. And then this is a case we had yesterday or today, I think last night late. No, Tuesday night late. So this is a person who presented with a stroke, and they were looking for a source, and they thought they saw something on echo, which they did. And we can see here that there is this large Goomba, well, not that large, perfectly sized. The classical size of these are about 9 millimeters to a centimeter. This was a centimeter by a centimeter by 9 millimeter hypoattenuating focus attached to the really recommissure between the left and non-cusp. So here's the non-coronary and here's the left. And, I'm sorry, I'm I'm an idiot. Sorry, this is non, so between the left and right. And there's this nice hypotenuating focus. I included cine movies, which unfortunately are dose modulated, so you can see it bop around a little bit. But this person presented with, initially with an MCA infarct. So let's go up higher to the brain. And wait, maybe, what am I missing here? So there we go. So you can see here the MCA just kind of ends, and there's a bunch. I have a bunch of other. We have nice MIPS and all these different things showing the obstruction here of the MCA. And the patient presented with MCA stroke. They treated the patient with. They got them to the ER quick enough. They treated him with anticoagulation, catheter-directed thrombolysis, and it didn't work. So they went in and did an embolectomy and sucked out pieces of tissue. So this was and then here's the kind of residual. You can see kind of this decent-sized MCA stroke. So this was a relatively younger person, 50-ish, who had a stroke from a papillary, I don't have path on it yet, but what I would presume, and that is a papillary fibroblastoma, which aren't actually that uncommon pathologically. Our pathologists see them quite frequently, but they're usually minuscule, few millimeter or two. These ones that are centimeter or so are less common, but that was a pretty case, unfortunate result. So those are my cases.
Which valve is usually affected? I'm trying to remember.
Aortic.
Right there. Okay.
It's aortic and then mitral. I've only seen one mitral, but our pathologist again says when he does these mitral valves from surgery that they're not uncommon to see tiny ones attached to the valve when you actually look at it and put it under the microscope. But aortic is the most common.
Wow. Okay, thank you.
Yep.
Great. Okay, David, you're up next.
That'd be fine.
Great. Good.
So I have two cases that have to do with the diaphragm, the magnificent organ of the diaphragm. And this is a man who has a syndrome called stiff. It used to be called stiff man syndrome. It's now stiff person syndrome. But I think under the Trump administration that may be changed back to stiff man syndrome because we're not going to be politically correct anymore. But he had rigidity of his abdominal musculature, and that means that his diaphragm has had to work against an abdomen that won't relax. Normally when you try to breathe in, your abdomen relaxes so that your diaphragm can move down and your abdomen can bulge out. If your abdominal wall is tense, then the diaphragm has to work much harder to get the diaphragm down against that tense abdominal wall. And you can see that that has resulted in this tremendous hypertrophy of the crus of both hemidiaphragms and the posterior aspects of the diaphragm. So this man has this massive hypertrophy here of his diaphragm crura because of this stiff man syndrome. He's on our service because one of the experimental treatments for this is stem cell transplantation. So he's had a stem cell transplant. And a year later, he actually has less hypertrophy after the transplant. He has less rigidity, and his diaphragm muscle has regressed a little bit, although it's still thicker than normal. So his chest radiograph shows pretty normal lung volume. Here you can see his chemoport catheter in place.
Stiff man and stem cell. Wow, really?
Stiff man and stem cell. So no halfway measures around here. Okay, then I wanted to bring back this case that I showed several months ago, and this was a woman who had these preoperative radiographs showing normal height of the diaphragm on both sides, and on lateral view, she might have a little bit of eventration. It's not very impressive. She had a plate placed in her right distal arm, and then had surgery to remove that plate, and this was done with a nerve block. So she got a brachial plexus nerve block, and then she had this pin removed from her wrist. And after the surgery, it was noted on this postoperative radiograph. Their concern, of course, was pneumothorax, and there wasn't pneumothorax, but her right hemidiaphragm is now elevated compared to what it was before. So here it was before, and here it is now. So she was followed outside for a while, and she didn't get a postoperative radiograph to see whether this, after the anesthesia wore off, whether the right hemidiaphragm elevation returned to normal. So it took actually a couple of months to get a post-op radiograph because she had some intervening medical problems. But here she is, several months now after that procedure, and you can see that when the anesthesia wore off, the hemidiaphragm was no longer paralyzed. So it wasn't as if this were, say, needle trauma that had done this. It was just the anesthetic agent. So when I showed this case before, I didn't have the follow-up radiograph to show that she'd recovered normal height to her right hemidiaphragm.
Yeah.
Okay.
Example of that.
So those are the two diaphragm cases I wanted to show. Thank you.
Great. Anyone else? Brent, do you have any cases this week?
Yes, I do.
Okay. There you go.
Okay. Let me pull this up.
See you now.
Okay. This is a patient who is who has one of the prettiest cases of this that I've ever seen, and this is courtesy of Arthur Stillman, who alerted me to this. This is a patient, of course, who is about 5 or 7 years after lung transplantation, double lung transplantation, and has this diffuse mosaic, very pretty mosaic attenuation pattern. And you can see that, of course, in the areas of lucency, as you'd expect, the vessel diameters are small. In the areas of higher attenuation lung, the vessels are more normal in caliber. And so this is inspiration, this is expiration. And you can see that there is extensive air trapping throughout all lobes of the lungs. And another finding that will come to in a second. But this is, of course, a really pretty case of bronchiolitis obliterans after lung transplantation. And let me show you one other finding here. This is on inspiration, and you can see that, and I know Travis and others have shown several cases of this, but this is a trachea that even if you didn't have an expiratory series, you would be concerned about this trachea because it has a lemon shape, or some people would say a lunate shape, which is highly associated with tracheomalacia. And if we look at the expiration, not only do we see the extensive air trapping within the lungs, but we see this severe collapse of the intrathoracic trachea, and this is of course, the frown sign. And so, this patient also has this severe tracheobronchomalacia, and in fact, the proximal bronchi, sorry I didn't load the other case, but there was another CT in which you could see that the mainstem bronchi also collapsed as well. So the only thing that surprised me about this case is that the FEV1 to FVC ratio was not worse than it actually was. It's about 60% on the PFT. So I would have expected that the combination of this and the bronchiolitis obliterans would have caused an even more obstructive pattern. But this is one of the prettiest cases I've seen of an extensive bronchiolitis obliterans.
What was the lung transplant for, and how old was this person?
This was, I believe, for COPD, and this was a patient, I believe, in the 60s. So here's another. Let me see if I can bring up the. Let me bring up the. Can you see my screen?
Not yet.
Okay, let me. Okay.
Good.
This. You see it?
Yep.
Okay. This is a patient who came in with. Let me try to pull up the CT here before. He came in at baseline with this CT. You see just a little bit of ground glass opacity in the left upper lobe here. This is a patient who had chronic renal failure and who's undergoing, can't actually remember the indication for this particular CT. But on the second CT that was done about a year later after the CT, look at that same area of the upper lobe here. And let me bring the left upper lobe here back again. And now you see that there's more focal ground glass opacity here, and there's also a nodule here, a solid nodule within this. And this, I think, rightly was read as, could this be a developing adenocarcinoma of the lung? And so that triggered a workup, diagnostic workup in this case. And just going through the rest of the lung bases, you see a little bit of ground glass here as well in the lower lobes. Some of this, to my eye at least, looks like it's clustered central-lobular ground glass nodularity, and you see some more regional ground glass in the lingula. And so this triggered a core, percutaneous core lung biopsy targeting this particular region of the lung. And I'll tell you that adenocarcinoma was not diagnosed here, and it's just interesting because this turned out to be a focus of nodular ossification fibrosis that was read to be metastatic calcification in the setting of renal, chronic renal failure. And so I think it's a very interesting case where you had a little bit of early metastatic calcification that actually started off like this and became a little bit more solid here, and is presumably going to be evolving in the rest of the lungs. But nice case of presumably early metastatic calcification in the setting of chronic renal disease that was interpreted originally as concerning for an adenocarcinoma. Has anyone seen, this particular type of scenario before?
No, so focal and so focal, and that little dot. No, that's really weird. Outright weird.
Yeah. Very weird.
In the setting of renal failure and an abnormal calcium phosphate product, anytime there's any pathology in the lung that changes the pH toward an alkaline pH, then you can deposit calcium there. If you've already got an abnormal calcium product just waiting to precipitate out. So we do see calcified infarctions. I think that maybe what Travis showed us at the beginning. We see definitely calcified infections. So this was probably some inflammatory focus that because of the abnormal calcium product is progressively or it has progressively calcified. It may stabilize at this point. It doesn't have to progress. So I think there was probably something special that happened to that part of the lung.
Yeah, that's a very interesting idea. That's that makes a lot of sense. So, all right, and I just want to show maybe one more. Actually, let me show this one because I promised to show this, and this is a case that I know Travis is familiar with, and it's from here. And you can see that I think I don't know if you all got it, but I sent this to Howard and David. It may have bounced back, but I sent this via a link. So if you didn't get it, I'll send it again. But this is a patient who has sarcoidosis.
Yes, Brent, don't see your screen yet.
Oh, sorry. Okay, so this is kind of the first study that we have showing this is a patient with sarcoidosis, and you can see the typical appearance of the sort of progressive massive fibrosis appearance with hilar retraction, severe upper lobe volume loss, and architectural distortion here with some confluent masses in the upper lobes. And then here's the next study plain film that we have here, and you can tell that something has happened here. You have these stents here projecting over the the left hilum here. And the question is, what happened? Well, the following is what happened. So here's a CT that was done showing the following phenomenon. You can see that if you look at the upper lobe pulmonary veins, the superior pulmonary vein on the left here, follow it up, it's very narrowed by all of this confluent hilar mediastinal soft tissue. So it's very, very narrowed and progresses up here, and you can see that other pulmonary veins from draining into the superior pulmonary vein are also narrowed as well. So this patient was very symptomatic, and I'm not sure exactly why they thought that this particular abnormality was causing even more dyspnea than baseline. But what happened was they actually, as you could see, stented those pulmonary veins that were draining the left upper lobe to try to overcome this obstruction. But this is one of the cases that looks very much like a fibrosing mediastinitis with respect to the mediastinum and hyla, causing severe stenosis of the pulmonary veins that I was talking about a couple of weeks ago. So so this is, you can tell that this is abnormal soft tissue that's partially calcified, and this is what is causing this pulmonary vein narrowing here. So you can see again that this was stented. So, however, this is one of the cases that we have of sarcoid causing pulmonary vein narrowing.
And it looks as if they operate on the other side too. Did they do the right?
And they didn't do the right side for some reason at this point, but you're right. Those are also narrowed as well, and we can see the upper lobe veins here more clearly on the coronal. They're being narrowed severely by this soft tissue, nodal tissue.
But Brent, on your second plain film, it looked as if there were stents on the right.
There were surgical staples, right?
Right. Yeah. Yeah, you're right. There are a couple of stents there. So I beg your pardon. Those were stented too. Yeah. So anyway, that's
very cool. Thank you very much for showing that.
Hey, Brent, do you have the VQ scans, or at least the quantified perfusion scans? Because I'm sure that this is one of Vasilis's patients.
Yeah, I think I do have those. I'll bring those next time. So I don't have those, unfortunately, in this stack, so I'll bring those next time. So can I show just one more, because this is a dramatic one?
Sure.
Just one last one. Let me bring up the screen here. Okay. All right, so this is just a bizarre anatomy case. This is a patient who had a right aortic arch and who had tetralogy that was repaired. And I'll scan down here and show you the VSD patch and the overriding aorta here that was repaired. But my concern here is the pulmonary arteries. So you can see, first of all, that look at how the pulmonary arteries make a crisscross morphology here. So this is a case of a crisscross morphology of the pulmonary arteries, where they sort of rise on the opposite side of where they're going. So the left PA rises more to the right than the right PA does, which rises more to the left than the left PA does. So it's a crisscross set of pulmonary arteries here, which in itself is very interesting. But look at this pulmonary artery right here, this branch. Let me show you. It comes up here. It comes off of the pulmonary artery there, and then it goes over and it crosses the mediastinum, and it comes out the other side, and it goes in front of the bronchus, and it heads up here. And of course, you can see there's a pulmonary embolus here, incidentally, in another pulmonary. But really, this is the only case I remember seeing ever that you had a pulmonary artery that was reaching over to the other side through the mediastinum and supplying the other lung. So I just thought that was an extremely cool case.
Wow.
Has anyone else seen that?
Nope.
Seth, have you seen crisscross before? Has anybody seen crisscross pulmonary arteries before? This is my first case ever.
I think, didn't Howard show one a couple years ago that was kind of similar? It didn't have a lot of other things, but it had some weird crisscross.
Not me. I think maybe Travis.
But it should be
Now we do have another case here of crisscross pulmonaries that I'll bring next time just to show a comparison. But you know, I just get excited when I see this. This is this is rare in itself, but then you know I've never seen this type of arterial supply. But anyway, that's all I have this week.
How did the abdomen look? Was the gastric bubble on the right side, and was the spleen doing what it should, and stuff like that, or is there more sinus difficulty in this person? Everything looks cool there.
It was normal here, yeah.
This person doesn't seem to have firm notions of right and left.
Right.
A lot of strange vessels going in different places there too. I don't get this.
Anyway, that's
way cool.
Right.
All right, thank you very much, everyone. Those were great cases.
Thanks a lot.
Adjourn and see you next week. Thank you. Bye.